Morning, everyone. Thank you for joining Cardiac Sciences Grand Round session. It's my great pleasure to introduce Dr. Luciano Sposato. Dr. Sposato is a professor of neurology at the Department of Clinical Neurological Sciences at London Health Sciences Centre at Western University in London, Ontario, where I did some training many moons ago. He's a stroke neurologist and a clinician researcher with cross appointments with the Departments of Epidemiology and Biostatistics and Anatomy and Cell Biology at Western University. He is the head of the stroke program and holds the Barnett Chair in Stroke Research and is the director of the Heart and Brain Lab at Western University. He's also the chair of the World Stroke Organization Brain and Heart Task Force and associate scientist at the Robarts Research Institute, where I spent a lot of time developing that infamous atrial fib model. He's a member of the editorial board and serves as editor of the neurocardiology section of Stroke, the American Heart Association, and is a member of the editorial board of neurology, the American Academy of Neurology. His research focuses on brain and heart connection and leads a multidisciplinary and translational research program involving epidemiological, clinical, and experimental studies. His most impactful contribution includes the description of clinical and pathophysiological concept of AFDAS, which means atrial fibrillation detected after stroke, and the pathophysiological processes leading to cardiovascular complication in stroke patients called SIHI, stroke-induced heart injury. He has published over 170 papers. His IH index is 48, has over 40,000 citations, more than 7,000 just in this year, 2021. I've had the pleasure of knowing Luciano for quite some time. Matter of fact, I tried to recruit him over to McMaster, but he decided to go to Western back in the mid 2000s. So he's a great friend and we do some research together. So it's a great pleasure to have Luciano today with us. Luciano, thanks for joining us.
Thank you, Carlos, for the invitation. It's my great pleasure to be here presenting with you. So I'm going to move. I'm going to start with a presentation about tackling post-stroke cardiovascular complication and why I think there's room or rationale for a randomized clinical trial for preventing cardiovascular complications after stroke. So let's see if we can move here. These are my disclosures. And overall, in terms of the outline, I'm going to talk about the stroke heart syndrome. This is something that you might be familiar with, which includes all the complications that involve the heart after stroke of any type. I'm going to talk about stroke-induced heart injury, or SIHI as we call it. It's a pathophysiological process leading to the stroke heart syndrome. Then how to tackle the autonomic and inflammatory pathways that lead to SIHI, and the proposal for a randomized clinical trial. So in terms of the cardiovascular complications after stroke, we know that there are about 1.5 million deaths yearly caused by neurocardiogenic deaths or neurocardiogenic syndromes. Among them, 1 million are exclusively caused by stroke-related cardiovascular deaths. And then we have other types of neurocardiogenic syndromes that lead potentially to death, which are the Takotsubo syndrome that you're very familiar with, SUDEP, which occurs after seizures, or neurogenic sudden cardiac death. Perhaps the most important aspect of cardiovascular death after stroke is that they tend to happen more frequently within the first 3 to 4 weeks, or I would say within the first month. And as you will see in the next few slides, cardiovascular death, it's just the tip of the iceberg. It's not the most, I would say it's perhaps the most catastrophic complication, but it's not the only one. There are several other cardiovascular complications that we see very frequently after stroke. Perhaps the most common one is the elevation of cardiac troponin, which we define as a rise and fall pattern. You know, patients can have an elevated cardiac troponin chronically, and that's chronic myocardial injury, which is related to several risk factors. But if we see that the cardiac troponin increases soon after stroke and then goes back to its baseline, that's what we call acute myocardial injury secondary to stroke. Then we have acute coronary syndromes, which could include acute MI or non-MI acute coronary syndromes as well, which are fairly common, as you already know. And then most interestingly, we see very frequently or quite frequently asymptomatic left ventricular dysfunction that recovers a few months after stroke. Patients with stroke have a higher risk of incident heart failure, and there have been some cases of Takotsubo syndrome post-stroke described in the literature. Another very common abnormality is the presence of asymptomatic EKG or ECG changes, mostly ST or T changes. And then the concept of atrial fibrillation detected after stroke, which I will not talk a lot about today, but basically it's the presence of neurocardiogenic forms of atrial fibrillation triggered by autonomic dysfunction or inflammation, or the presence of SCAF or subclinical atrial fibrillation that is detected after stroke and does not have a specific role in the pathophysiology of those strokes. So all these symptoms are known as the stroke heart syndrome, which has been described by the group of Scheitz and collaborators at Berlin in Lancet Neurology, and we have recently redefined in a recent paper published in JACC. So from epidemiological data, we know that within the first year after stroke, the most common single complication that patients experience is a major adverse cardiovascular event, not including a recurrent stroke. Patients may also experience an acute ischemic stroke or TIA, a recurrent event, in 8.6% of the cases, and ICH or intracranial or intracerebral hemorrhages are less frequent. So these are data coming from Ontario, from a population-based study in which we measured these complications. At 3 years, major adverse cardiovascular events are still more frequent than any single cerebrovascular recurrence. So why is this happening? Why are patients with stroke still experiencing MACE or cardiovascular complications, even though we have learned to prevent stroke much more efficiently? We have introduced, or patients are more compliant with diet, exercise, and a healthy lifestyle. There are still things happening, and we call this the residual risk of cardiovascular complications, which cannot be prevented by the usual measures that we implement for secondary stroke prevention, which basically means that by controlling risk factors using antiplatelet agents, statins, or other classical drugs, we are not able to prevent MACE. And that's because we are probably not targeting the adequate mechanisms that lead to cardiovascular complications after stroke. So for better understanding how to prevent those complications, we have proposed in the past that we would need to conduct preclinical studies to understand mechanisms, and we would need to conduct epidemiological studies to know better about clinical outcomes and which are the populations at risk. So focusing on epidemiological studies, we can investigate what the stroke heart syndrome is and what the implications are at the population level. These are two recent studies that we have published last year, in which we evaluated the whole population of Ontario. We looked for first ever ischemic strokes and the risk of cardiovascular complications, and then we stratified that analysis for men and women. So basically what we did was to look for patients with ischemic stroke happened between 2002 and 2012. And then we used a control group, which was the remaining of the Ontario population. Sorry for that. It's 20 million people, as you can see here. We applied some exclusion criteria, such as recent cancer, previous stroke, or any kind of known cardiovascular disease. So we excluded patients with known heart problems, right? So we then applied propensity matching using 31 variables to identify a control group that would match patients with first ever ischemic stroke. And we looked at the risk or the rates of cardiovascular complications after adjusting for the competing risk of death, and further adjusting for variables that we thought we had a residual difference after propensity matching. So what we found in unadjusted analysis is that the risk of ischemic stroke in matched controls, compared to matched controls, was much higher, as you can see here, over a period of 36 months, 3 years. When looking at each of the components of MACE, which were myocardial infarction, unstable angina, a new diagnosis of coronary artery disease, the need for an urgent PCI or CABG, or incident heart failure, and also including cardiovascular death, but not incident AFib. Most of them had significant differences on non-adjusted analysis, but compared to a propensity matched cohort. We decided not to include incident AFib because we know that patients undergo very thorough ECG monitoring after stroke, so that could introduce some bias, and we just considered incident AF, or AFDAS as we call it, as a secondary outcome. Perhaps the most important factor is that of these results is that at 30 days, or within the first 30 days on fully adjusted models, we found that the risk of MACE in patients with a first ever ischemic stroke was 25 higher than for propensity matched controls without stroke. And so just as a reminder, these are patients who never had or who did not have any history, or at least known history of heart disease, who had a first ever ischemic stroke, and we compare them to people without strokes. So it seems that the rate of cardiovascular complications after stroke is has a very time-varying pattern, which is highest in the first 30 days. But it remains significant at 90 days, as you can see here, 5-fold higher, and at 2 years, at 1 year, as you can see here, with a 2-fold or twice higher risk. We further looked at these results at 3 years, and this difference that you can see here remained significant on fully adjusted models. So the take-home message here is that patients are at a very high risk of cardiovascular complications within the first 30 days, which makes sense considering the previous data that I showed you at the beginning of the presentation. So in terms of stratifying analysis for men and women, we found that the curves were pretty similar. There were not substantial differences, or they were actually strikingly similar. And this is interesting because it can be hypothesized that the reason why patients have cardiovascular complications after stroke is because they have subclinical coronary artery disease, for example, and that becomes more clinically evident, or coronary events are triggered by the stroke itself. But we know that subclinical coronary artery disease in patients with stroke is 8-fold higher in men compared to women. So that doesn't seem to explain the overall risk of cardiovascular complications after stroke. And there needs to be, or there's clearly other mechanisms explaining these complications. So for understanding those mechanisms, we thought that we would need preclinical studies, rat models, because it is very difficult to follow up patients until they have the stroke, and then continue to follow up them at a clinical level that would require a huge effort and hundreds of thousands of patients. So in the controlled preclinical environment, we could develop a stroke-induced heart injury model in which we could cause strokes to rats and then see what happens to their hearts. And that's how we developed the concept of SIHI, which involves 3 levels of action. The first one is the brain, then the systemic circulation, and then the heart. So in terms of what happens within the brain after stroke, we know that there is neuronal death, and then the microglia becomes activated, and that releases pro-interleukin-1 beta, which is further increased by phagocytosis of cell debris by other activated microglia. So once we have pro-interleukin-1 beta, the activation of the inflammasome caspase-1 complex activates pro-interleukin-1 beta into interleukin-1 beta, and that is the key of the whole process. Interleukin-1 beta, or interleukin-1 alpha as well, but not so importantly, are the ones who act on the interleukin-1 receptor systemically and in the heart, and that causes most of the complications. So to further look at this in rat models, we injected saline solution in rats on the right and left insular cortex. Here I'm showing just the right insular cortex. And we also injected endothelin-1, which, you know, it's a very potent vasoconstrictor. We injected it on the right side, and we looked at the brain of the rats at different time points. I'm going to skip the first few weeks, and I'm going to go to day 28, in which we see that within the right hemisphere, the same hemisphere where the interleukin-1, the ET1 injection happened, there is a lot of activated microglia, both M1 and M2. As you know, in general, we consider that M1 microglia is the one that protects, damages the brain, causing neuronal death, and then we have the M2 microglia, which helps in terms of recovery. So there is a clear fight here in terms of inflammation that persists at least at 28 days after the stroke, and may cause a lot of cognitive impairment and perpetuation of inflammation, or making it chronic, which consequences over the heart. So what we know about the interleukin-1 beta is that it is increased in patients, in the CSF of patients with stroke, which means that it's locally produced. The concentrations are higher in the CSF compared to serum, which means again that it's produced in the CSF, and the production is in relation with stroke severity. The larger the strokes, the higher the concentrations or levels of interleukin-1 beta. So what happens at the second level, which is the systemic one? First of all, interleukin-1 beta acts over interleukin-1 receptors at the level of the adrenal gland, and that stimulates the release of adrenaline and noradrenaline, with the consequent release of systemic catecholamines into the bloodstream. At the same time, as I showed you, there are lots of things happening within the brain, and that results in malfunction of the autonomic nuclei within the brainstem, and that results in autonomic dysregulation of the heart, and I'll show you more data about that later. At the same time, that dysregulation leads to the activation of adrenaline receptors within the adrenal gland, and that further increases the release of catecholamines. And at the level of the spleen and bone marrow, there is activation of monocytes into macrophages, the release of neutrophils and macrophages into systemic circulation, which is further stimulated by norepinephrine over alpha receptors on the same organs. And finally, the norepinephrine or adrenaline acts over the same cells that were released from the spleen and bone marrow, further increasing the release of interleukin-1 beta. So this is all that happens at the level of the systemic circulation, which obviously has implications on the heart, and I'll show you that later. When we measured interleukin-1 levels in rats with endothelin-1 insular stroke compared to those with the injection of saline, we found that there was a peak at 6 hours. There's a very early peak of interleukin-1 in the serum of rats with strokes, and then there is another peak at 28 days, meaning that there seems to be a rebound inflammation phenomenon at 28 days that we hypothesize that could be prevented by preventing the first peak. So at the heart level and the myocardium, the interleukin-1 that was released systemically acts over inflammatory cells, which further activates fibroblasts into myofibroblasts, and that generates fibrosis, which in the future can lead to arrhythmias. There is a massive release of norepinephrine, mostly because there is nerve growth factor released by the myocardial cells, which causes sprouting of the sympathetic nerves. So there are thousands of sympathetic nerves that are growing within the myocardium, further releasing more norepinephrine. That results in increased oxygen demand with necrosis and apoptosis, which further leads to heart failure or acute coronary events. There are some actions of interleukin-1 over the blood vessels, causing plaque rupture in the acute phase, or atherogenesis on endothelial dysfunction a little bit later, with more recruitment of leukocytes and leading to chronic inflammation within the heart. The direct action of catecholamines leads to contraction band necrosis, which is quite typical of stressful situations, and subendocardial hemorrhages with further causes arrhythmias because of the involvement of the conduction system. So as you can see here, this is a proper or actual SIHI or stroke-induced heart injury, but it highly depends on what happens systemically and first of all, what happens in the brain. So to further understand this, we created this insular stroke model. You know that the insular cortex is, has a very important role in the autonomic regulation of the heart in very different aspects of heart function. So we caused strokes in the right and left insular cortex by stereotactic surgery, injecting endothelin-1 in those hemispheres very selectively. And we looked at brain infarcts at 28 days and the conditions in which the myocardium was left at the same time. So here I'm showing you panleukocytes, neutrophils, T lymphocytes and B lymphocytes in rats who received saline injection and rats who received endothelin-1, both in the left insular cortex and right insular cortex. And as you can see here, both visually and in the charts, there is a quite substantial difference in terms of inflammation measured as any of these parameters in rats who received endothelin-1 compared to those who received saline solution. So this means that those strokes are causing inflammation even at 28 days. And this is, of course, the left atrium, what we're looking at. So it means that whatever happens in the brain 20 days before is affecting the heart chronically in terms of inflammation. There is also endothelial dysfunction. As you can see here, those arrows here are showing dysfunctional endothelial cells in the left atrium, in the microcoronary arteries, and as both visually and numerically, there is a difference in which shows that there is higher or more severe endothelial dysfunction in rats who received endothelin-1 compared to those who received saline. And perhaps the most striking finding is the presence of fibrosis in the left atrium in rats who received strokes compared to the controls. And this is whatever you see here in blue, and the trichromic, MACE and trichromic stain is fibrosis, and it's around only at 28 days, there is almost 6 to 8% fibrosis of the left atrium. So there's a huge amount of very early fibrosis. And the main reason, once we found that, we thought that the main reason why that was happening so selectively in the left insular, in the left atrium was because of the connection with the parasympathetic and sympathetic nerves with the ganglionated plexi at the level of the atrial tissue, which is surrounding the pulmonary veins. So we further explored that, and we looked at the amount of fibrosis that we could see surrounding the pulmonary veins and in more distal parts of the left atrium. And we found that only in rats with strokes, there was a difference showing more fibrosis within the pulmonary veins compared to more distal left atrial tissue. And we also found, as you can see here, more inflammation surrounding the ganglionated plexi. As you can see in brown, these are T lymphocytes and these are the plexi. So overall, there seems to be quite substantial fibrosis surrounding the pulmonary veins. We know that this is a process that comes with age, but it was highly enhanced in rats who received strokes compared to those who did not receive strokes. So the interesting thing is that when we looked at the timeline of those changes, we found that differences in fibrosis in the left atrial pulmonary vein border were already significant at 14 days. So fibrosis starts happening at around 24 hours after stroke onset, and 14 days is already quite significant compared to rats who did not receive strokes. And other interesting factor is that when comparing microglia activation in different parts of the brain, as you can see here, forceps minor, corpus callosum, internal capsule, or the thalamus, there is a quite substantial correlation with the amount of fibrosis that we see in the left atrium. So everything points to the fact that most likely all the inflammation that we're seeing in the left atrium is happening because of inflammation happening in the brain. So to summarize, there are things happening in the brain systemically and in the heart that lead to stroke-induced heart injury. And as you can see here, interleukin-1 beta and catecholamines have a major role in the pathophysiology of stroke-induced heart injury. So we thought that we might be at the right time to start looking at potential treatments to reduce this residual risk of cardiovascular complications after stroke by tackling the autonomic and inflammatory pathways. And this is what I'm going to show you now. In terms of possible endpoints for a clinical trial, we will look at cardiovascular endpoints such as acute myocardial infarction, non-MI, acute coronary syndromes, admissions for congestive heart failure or cardiovascular death. And in terms of strokes, we will look at recurrent ischemic strokes, the occurrence of hemorrhagic stroke, and stroke-related deaths. Of course, we should also look at cognitive outcomes because inflammation post-stroke is highly correlated with cognition. So in terms of tackling the autonomic pathway, this is what I showed you before. Carvedilol seems to be the ideal drug because it acts over alpha and beta receptors and also seems to have anti-inflammatory properties. As we can see here, it could act over the massive release of catecholamines on the heart. And interestingly, when looking at outcomes in rat models of MCA occlusion, what you are seeing here is apoptosis based on tunnel staining in rats at 24 hours after 180 minutes of transient occlusion of the MCA. And this is by using carvedilol at 1 milligram kilogram, 3 and 10 milligram kilograms. And it seems to have anti-inflammatory properties on the brain, which means that it will not only help for preventing cardiovascular complications, but may also help for preventing cognitive outcomes in patients with stroke. In terms of the inflammatory pathway, there are two candidate drugs that are currently on the market. Anakinra is a recombinant human interleukin-1 receptor antagonist, which is used for rheumatoid arthritis and has been in the market for many, many years. And it non-selectively blocks the interleukin-1 receptor, so it blocks both interleukin-1 alpha and interleukin-1 beta. It is administered subcutaneously at a dose of 100 milligrams once or twice daily. And the problem that it has is that it needs to be administered throughout the whole period in which cardiovascular complications may happen, which means that patients will have to receive this for months, or at least it could be possible to try to block the acute inflammatory response and see if that leads to a lower chronic inflammatory response. We have Canakinumab available also, which is a human monoclonal IgG1 antibody, which selectively blocks interleukin-1 beta, preventing it from targeting the receptor. There are other drugs that are under investigation, but they're not ready in the market. So the important aspect of interleukin-1 receptor antagonist in animal models, this is a systematic review of 25 preclinical studies, including over 1,200 animals. By using these drugs, the brain infarct size has been reduced to 36%. Behavioral measures have improved 36%. Motor and sensory outcomes have also improved by 36%. And mortality has not changed. So there's not a substantial change in mortality. Important thing about these results is that it's at least they seem to be safe in rat models in terms of human, or I'm sorry, brain outcomes. So Another important aspect is that the results did not differ in animals receiving TPA, so there doesn't seem to be a huge interaction with TPA, which is also or always a concern. And by administering interleukin-1 to pre-stroke, pre-strokes in these models worsen outcomes. So it seems that it's a tight correlation between interleukin-1 and outcomes in stroke patients. In terms of canakinumab, there is another MCAO model in mice, in which they used canakinumab in these rats. They initially found that in the ipsilateral hemisphere there was an increase in interleukin-1 beta, but importantly, after the administration of canakinumab, there was a decrease in interleukin-1 beta in the rats who received the drug compared to those who received a vehicle. So in terms of these drugs, they overall, and based on animal models, they seem to be safe. I would say at least safe for the brain, and they may work for preventing cardiovascular complications. There is just, actually there are 2 human studies in which anakinra has been used for stroke patients. These are very small studies in which they used interleukin, they used anakinra to see how the outcomes were in terms of interleukin-6 levels, which is a mediator of most of the damage caused by interleukin-1. And they saw that there were no differences in modified Rankin scale and 90 days, which means that, again, it seems to be at least safe for humans, for the human brain. And in terms of the results of interleukin-1/6, there was a massive reduction in interleukin-1/6 levels at 3 days, which means that all the damage that is caused by interleukin-1/6 could be prevented in the heart, hopefully. There were, in terms of outcomes in the placebo and anakinra groups, there were more neurological deteriorations, numerically more, but non-significant because of the low end of the study. And if you see most of the complications are more frequent in the placebo group. I marked here pneumonia because when we're using drugs that act over the immune system, there's a concern about infections, but at least based on this small study, there doesn't seem to be a huge concern. In terms of canakinumab in humans, we have CANTOS trial, which you are very familiar with, in which they randomized patients to different doses of canakinumab if they had stable CAD with elevated CRP. And in terms of the results, they found that there was a reduction in the number of events in patients receiving canakinumab compared to placebo. And there was 35 to 40% reduction in CRP and interleukin-6 levels, which means that perhaps or most likely, most of these events were, the reduction in these events were mediated by the reduction in interleukin-6 levels. So this is maybe too complex by Paul Ridker, explaining how blocking interleukin-1 beta may help on MACE. But as you can see here, the main driver of those changes is interleukin-6, which is stimulated by interleukin-1 beta. So what Paul Ridker concludes is that for those considering whether or not to undertake the journey of a clinical trial in stroke, the time is now, and interleukin-1 beta inhibitors or blockers seem to be the right option. So perhaps the most proper design, and I would love to hear your thoughts. It's a 2x2 factorial design in which we would use carvedilol plus interleukin-1 receptor antagonists. In another group, we would use just interleukin antagonist alone, another group with placebo, another group with carvedilol alone. And of course, the primary outcome should be the one that I showed you before. So I think this is all for now. I'll stop sharing my screen, and I'm very happy to take questions if there are any. Thank you for your attention.
Thanks, Luciano. That was fantastic. Very interesting. There's someone with a hand up. Catherine.
Hi, thank you. I enjoyed the talk. I know you call it stroke heart syndrome. Is there also heart stroke syndrome? In that some of the changes that we see with, or some of the things that we see with myocardial infarction and some of the biochemical or interleukin we may see with an MI, do we see an effect on the brain in those patients?
So you mean when patients had a myocardial infarction, if there are any consequences on the brain?
Right.
Yeah, and that's a great question. I don't think there's a lot of evidence about that, but of course we know that we usually tend to think that most strokes after a myocardial infarction happen because of an anterior wall infarct with a thrombus and then cardioembolic strokes. But I'm not sure that we have actually measured that cognitive outcomes exclusively related to myocardial infarction, and that we can implicate myocardial infarction in cognitive outcomes. We know that cardiovascular surgery has major impacts on cognition, mostly CABG, on-pump CABG, and that's something that is very well measured. That could be both because of inflammation or microembolic hits on the brain.
Thank you.
No problem.
So there's a question here. Do you think that anakinra and canakinumab might improve neurological outcomes in out-of-hospital cardiac arrest?
Interesting. Well, there is a lot of inflammation also secondary to hypoxia in cardiac arrest. So they may help, but and I know the beauty of that is that they can be given just immediately after cardiac arrest in the ambulance. So it would be fairly feasible to do that, but they would have to be tested in a clinical trial.
So Dr. Raj is asking if you think that central sympathetic medication like long-acting clonidine or methyldopa might help to prevent SIHI.
It is possible. We have tested. Can't remember the name of the antibiotics that we know to have anti-inflammatory properties. We have tested them in rats with striatal strokes, which do not involve the insular cortex, and they work. So any drug that has anti-inflammatory properties may help prevent these complications, or any drug that has autonomic regulation effects can help. Problem is selecting the candidate one, the one that is most likely to work, right?
Another question here from Dr. Mustafa. Amazing talk. Out of curiosity, is there any correlation between the size of the stroke and for example, the degree of troponin rise from an increase in the ILB levels?
Yes, there are some studies showing that first, insular cortex strokes are related to the rise and fall pattern of troponin, and number two, that the larger the stroke, the higher the concentrations or levels of troponin levels. And there's when there is some confounding between size of the stroke and insular cortex involvement, because we don't know if it's just one or the other. These are very difficult studies to conduct, but there seems to be a relationship. And there's definitely a relationship between interleukin-1 and size of the stroke, and the size of the stroke.
So I was fascinated to see that some of the correlation with your insular strokes in the right side. That kind of, a long time ago when I was back there with Dave Cecchetto and Dr. Hachinsky, we did this study that I would go to the OR with Dr. Gervin and stimulate insular cortex and look at heart rate variability, baroreceptor sensitivity, and other things. And the fact is that, the right side seems to modulate mostly sympathetic traffic. So one of the questions is, you're going to use carvedilol, but carvedilol also basically increases vagal tone. So is the mechanism because of only reducing sympathetic tone, or there is an increase in vagal tone? And we know that increasing vagal tone, and that was going to be my follow-up question, it has an anti-inflammatory effect. So would maybe vagal stimulation, like the one that we use for vagal stimulators in epilepsy, be something that would be worth testing here?
Those are great points, Carlos. Those are, yeah, definitely vagal stimulation reduces inflammation. So that's why carvedilol could be a very good drug for this, right? And using vagal stimulation in the hyperacute setting, I think it might be a little bit challenging from a feasibility perspective. So that's why just using a drug that can be easily administered, we think it might be easier, right? But definitely there is a very important role of vagal stimulation and reduced inflammation.
The other question on that was that we saw some differences in whether it was the anterior or the posterior amygdala. Does your model show that also, or?
So what we know from the group of Berlin, that they have very sophisticated studies looking at voxel-based MRI analysis, which is adjusted for many other variables. It looks like it's more the right posterior insular cortex, the one that it's related to increases in troponin and myocardial injury. And you know, that correlates with the higher risk of death that we see in stroke patients when the right insular cortex is involved compared to no involvement of the insular cortex. But we do not see that on the left insular strokes. So yeah, the right one seems to be the high risk insula.
So does that mean for the trial, are you only going to include patients with right insular cortex strokes? So that's going to make it a tough one, because it seems that, you know, mechanistically that's where you want to aim, but is that worth it from the population kind of a intervention perspective?
That's another great point, Carlos. I think, no, we would first start with a pilot study, with a small one, and we would probably use the hemispheric lateralization as one of the randomization criteria, so that we have at least 50-50. We have 50 women, 50 men, 50% right and left insular cortex, so that we can have a better idea of how a larger randomized controlled trial should look like.
So a question I've never been able to answer myself: if you're a lefty, does that change the autonomic regulation?
That's something Dr. Haczynski has always been interested in. And
yeah, I know.
But I don't think there's a clear conclusion about that, because we know that 95% of the population has a left-sided lateralized functioning brain.
So there's a question here from Dr. Wilton that has anyone investigated an association between statin use and dosing in post-stroke MACE?
Yeah, so there are some meta-analyses showing that there might be some benefit, and that's possibly related because of the statins themselves and lowering the cholesterol, and on the other hand, because of the anti-inflammatory process. Of course, patients need to be on statins, but on top of that, they still continue to have more events, so it doesn't seem to be enough.
That residual risk is still there.
Yeah, exactly.
So when are you launching the pilot?
As soon as we get funding.
The $1 million question.
You know it.
Yeah, I know.
Yeah.
Well, we hope we can get some funding for that, because really it is a fascinating topic. And so another couple of questions that came to my mind when I was fascinated by the correlation with fibrosis at the pulmonary veins triggered by this. So one of my questions is, what would be the proportion of people that actually have atrial fibrillation that have silent cerebral ischemia that is actually triggering this?
So, well, we know very well that AFib is a clear cause, or it's very correlated with silent brain infarcts, and we actually call them covert brain infarcts, because we know that they are not actually silent, because they are related to higher risk of depression, dementia, and death. So it is possible that at the end of the road, those same silent brain infarcts can increase the risk of AFib, but I think it's the other way around in this case. I think AFib is the one that causes those silent brain infarcts that lead to neurological outcomes, rather than the other way around. However, in patients with Alzheimer's disease, for example, who have atrophy of most of the structures that are involved in autonomic regulation, We know that there are significant drops in their blood pressure at the end of their life, and that there are problems with autonomic regulation that are very likely related to that atrophy that we see in the brain.
Okay. Well, that was really fascinating, Luciano. Thank you very much. I don't know if there's any other questions. Satish, you're one of our autonomic guys. Any comments, questions? What do you think of the trial?
So I think it's this is an interesting area of study, and I've been interested in the reason I asked the clonidine question is that there are, I think, a lot of things where acute sympathetic surges can lead to downstream damage, and the beauty of clonidine, the downside of clonidine is it's poorly tolerated over a long time and it has short half-lives. The beauty of it is it's dirt cheap, right? So anything with an IB or an AB right now sounds like it's an expensive therapy and may have a specific niche, but if there's a way that you could target one mechanism, sort of hit the sympathetic outflow, if you think that's the trigger for the downstream inflammation, that's actually something that you could easily stock in every emergency department. I'd make a donation. I probably could cover the cost of every emergency department having 3 tablets of clonidine myself. It's so cheap.
Yeah.
But that's why I asked that question, whether you can pick just one. I mean, I think you're obviously taking a risk when you run the trial, right? You want to optimize the chance of not guessing wrong. Carvedilol is not too expensive, but the IBAB sounds like it's not a cheap, easy thing to do.
Yeah, that's actually a great point, and that's why I'm not such a big fan of Canakinumab, for example, because I know it won't be something that could be used for every stroke patient who comes to Demerge, right? And the same principle applies to clonidine. Yeah. There's so many options that sometimes it's difficult to choose.
Paralyzed by choice.
Yeah.
There you go. Yeah, like the Duff mentions here that carvedilol blocks RY1 receptor and RYR2 receptor, and is a strong antioxidant and activates capsase 1.
Yeah, another good reason.
There you go.
Thanks for the comment.
Okay, well, really fascinating. Hopefully we get funded for this and we get this going. Okay, Luciano, hope to see you sometime soon, and say hi to the family. Thank you
so
very
much for your attention and invitation. Bye-bye.
Okay, great. Thanks.